Dr. Dana Lustbader, board certified in critical care medicine, internal medicine, and palliative medicine, the chair of the Department of Palliative Care at ProHealth, which is a multi-specialty ACO serving over 1.5 million patients in the New York metropolitan area. Dr. Lustbader is the founder of Optum Supportive Care, which is an advanced illness management program that utilizes both in-home and telemedicine visits. She is teaching faculty at CAPC and a professor of clinical medicine at the Hofstra Northwell School of Medicine. Dana, thanks so much for spending some time with us and sharing some of your experiences. I guess my first question for you is, how are you doing?
Thank you, Len, and thank you so much for having me today. It's nice to talk to you and your audience. It's pretty overwhelming here in New York City, sort of the epicenter of the COVID pandemic. It's overwhelming in a lot of ways, and a lot of things that have changed in the way we have done things, both in the inpatient side and critical care, and also in palliative care. But the camaraderie and the way people have come together in New York is extraordinary. So a lot of support too.
So Dana, how has life changed for the practicing palliative care clinician in New York City during the pandemic?
Yeah, so I think the most striking difference I can just share last week walking into a hospital I worked in for 20 years and having um, ICU patients in labor and delivery and in the operating rooms and in the lobby of the hospital, and really converting a hospital that was 700 or 800 beds into a 1,200 bed hospital with, instead of 3 or 4 ICUs, 10 ICUs. And 700 or 800 COVID patients with 200 or 300 of them on ventilators just in one hospital. So just the extraordinary changes to the building. The people there are, of course, we brought in a lot of people from elsewhere. A lot of the nurses and docs come from all over the country. And so that's really very different and palpable. And then there are 2 large tents that have been put up in the parking lot to accommodate patients as well as in New York City. The Javits Center has been converted to a COVID unit, and the health system is running that. And then a ship to hold patients as well. So just physically, things very different. Everything pretty much in the hospitals these days is COVID, and so everybody there either has COVID or is on a ventilator with COVID.
Can you talk us through how some of the actual logistics of delivering care are changing during the pandemic?
So in my outpatient palliative care practice, we have converted almost all of those visits to telemedicine visits. We've been using telemedicine for 5 years. So our seriously ill community patients who've been getting home palliative care in the clinic, are getting everything virtually now. And they like it. They don't have to drive to the office. They don't have to go somewhere. We can set up a visit and do a virtual visit that way, or have a family meeting virtually. So I think a lot of patients are enjoying that increased access to telemedicine. Personal note, I did a virtual visit early this morning with my son with his gastroenterologist. He has celiac disease, and instead of having to go to Columbia University in New York City, the chair of the department scheduled a visit with my son, and we sat at the kitchen table and did a patient visit, and it was really wonderful. So there are some very good aspects of telemedicine that I hope will endure after the pandemic is over. As a user of those services, but also for our patients, I think they really do appreciate having this kind of connectivity if they're able to see us when they need us.
So you have probably more than 5 years of experience delivering palliative care via telemedicine in some capacity. Would you say that this is an extension of the way you've been delivering care, or would you say that this is just very different?
It definitely feels different. The urgency and importance of bringing the family in this way, because they're not physically there, makes it that much more important. So on Easter Sunday in this Queens hospital, which is all COVID, 400 or 500 COVID patients and a couple, maybe 100 or so intubated COVID patients. We're in a patient's room, and I wanted to do a virtual visit because this was an 88-year-old patient who was with renal failure on a ventilator, paralyzed with a medication to paralyze them so they wouldn't move, so they would synchronize with the ventilator better. And the son and daughter, who lived in separate states, wanted to see their father. So I got all gowned up and ready to go into the room, and the 2 nurses that were there were just about ready to bathe him and clean the sheets and do all this stuff. And bit irritated with me that I wanted to do this visit right now, but it's hard to know what's going on in the room when you're out of the room. And so the timing wasn't ideal, but I finally got in there with this iPad, and the daughter was waiting for the call first. So I didn't want to keep her waiting. So she got to say some words to her father, who was dying, but not acutely. But she really wanted to pray and say some words with him. So she had a very meaningful visit with him. While these two nurses are sort of watching, they had not seen this before. Then I hung up with her and did a second call with her brother. And her brother was saying an Easter prayer with this patient who's, again, sedated, paralyzed with a medication on a ventilator, and saying to his father, you can go now to your parents. They're calling you. It's okay, Dad. And it was very moving. The nurses started to get teary. It was a very moving moment, actually. And I left the room. And I started taking everything off, doffing all of my equipment and gear and everything. And the nurse came over to the door and she's like, Dana, he just went asystolic, meaning he had just died. And we had had a DNR discussion in that, and so we weren't going to resuscitate. But it was so interesting how that timing was so important. And I didn't expect him actually to die at that moment. I thought he had a day or two left, but just maybe hearing his son's words or his son giving him permission to see his parents. But it was really moving, and the staff was just very teared up. And it was, we all had to take a pause for a minute. And throughout the whole day, we hadn't really done that before, but it was really an important thing for the son and daughter, and it was really powerful for the staff.
That's incredibly moving, Dana. Thank you for sharing that story. Um, it introduces the question. So many clinicians are now finding themselves having um, really difficult goals of care conversations, in many cases for the first time. Is there any advice that you would give them for how best to deal with these situations and have these conversations?
I think we all kind of have a little script that's very helpful for us to practice and learn and even memorize so that we can do it well. Here I have learned a different script. And when I make a call to a family, whether it's a video call or a telephone call, I started out differently than I did in the past. And I always start out with, this is not an emergency. This is Dr. Dana. Uh, is this a good time to talk? And it's so important to say that because families at home are sitting on pins and needles. And if they get a call from a no ID, no caller ID, or a hospital or a doctor's office, their first go-to place is that mom or dad or my daughter, my son, my brother or sister has just died. And it's really important to start the call that way. Unless it is death notification, I don't start it that way. But if it's a regular family meeting or a goals of care conversation, or I'm just updating the family on something, this is not an emergency. This is Dr. Dana. Is this a good time to start? And I even use my first name because I just want to make it that much easier for them. If they ask my full name, I certainly give it. Then the second question I ask them is, how has coronavirus impacted you, or what impact has this had on you in the past day or two, or how has it impacted you? Because very often I find that somebody else has just gotten hospitalized or sick. Or last week when I asked that question, I was calling a patient's son, and I was speaking in Spanish because they didn't speak English and I speak Spanish, and he was telling me that he's 2 floors down below where we were. And I thought he looked like he was wearing familiar hospital garb, but he was literally 2 floors below where I was with his mother. So how has this impacted you? And he shared with me that he's in the same building with coronavirus as well. So it's always important to kind of see how this has impacted them. The third thing I like to ask is, what have the doctors told you so far? Because there are so many new people in here, and a lot of people in the ICUs or in the hospitals caring for patients that don't normally work in hospitals. So I don't really know what, if anything, has been communicated, and I don't know how well it's been communicated either. So it's good to hear what they've heard. And I always like to build upon that. I don't want to throw any colleagues under the bus. So I always say, yes, and here's what else we've seen. So, the rule is don't throw anyone under the bus, even if it's a little bit wrong, but it's like, yes, and I was thinking about it this way, or here's what I'm seeing today. And then the fourth thing I always say is, may I share with you some information just to update you now? asking them permission to give them some control over what's going to happen next. So those are the four ways I like to start. This is not an emergency. Is this a good time to talk? How has coronavirus impacted you? Um, what do you know so far? What have the doctors told you? And then asking permission. May I give you some update now on your mom or dad?
So, is there anything especially poignant, any moments that sort of grabbed you that you would like to share?
Yeah, I just even just yesterday I was in a unit and we had taken someone off a breathing machine successfully. He's probably in his late 50s, had been doing very, very well. And but the saturations, the oxygen saturations sometimes tend to be low in this disease, and we do tend to tolerate that. So we had been watching him closely, but he was very comfortable. He ate lunch, and we were watching him. And then around 7:30, 8 o'clock, as the shifts were starting to change, um, all of a sudden his alarm started to go off and he had a cardiac arrest. So we all ran in there because he had been looking so good, and we tried very hard to revive him with CPR and everything else, and it didn't work. And he died. And as we're all walking out, I noticed his nurse was sort of in the corner in the hall, and his shift had ended over, and he was not leaving, and he was just sort of like hunched over the computer, but he wasn't typing in, he wasn't even logged in. He was just teary. So I asked him if he was all right, and he said, he's just come up here from San Antonio, Texas. He's here for 3 months to help during the COVID pandemic, and this was only his third death in 7 years. And I just paused with him. I forgot what that's like. And I stayed with him. We then walked out to our cars together. He's living in a hotel for 3 months here to really contribute to this pandemic. And I had just forgotten, what that might feel like to someone who's not seeing death all the time. And it's just really important to be with people so that, because his service is just so greatly appreciated. He came here from Texas to help us. So we talked about what that meant to him. And he was an ER pediatric nurse, and so they don't see death there very often. And he has stepped up to help us in our time of need, and he's a superb nurse. But it was just a reminder that this is hitting people in a lot of different ways.
Dana, thank you so much for sharing your stories and your experiences. You're an amazing teacher, and well, for folks who don't know it, you'll be teaching again soon. You're going to be doing a virtual office hours offered through CAPSI, and I think we'll do our best to share that link too. It's capsi.org/events. Incredibly relevant topic. It's on moving an office or clinic-based palliative care program into telehealth or telemedicine. That's going to be on Monday, April 27th at 2 p.m. And let me just close by saying thank you again for sharing. Dana, you have for a couple years now been an incredible inspiration for me personally as I've become more involved in palliative care. You're an incredible mentor, teacher, incredibly active in the policy space. It has been an honor and a pleasure getting to talk to you today. Really appreciate it.
Thank you, Len. It's a pleasure. Thank you.